Much everyone for coming to this wonderful seminar that we are about to present on behalf of the Euretina imaging section. We're going to be talking about how can imaging help, and we will be having a whirlwind tour around loads of imaging modalities in retina. So I hope you will enjoy it. Those of you who are preparing for the exam, please remember that this will be available on the Euretina website later on. So without further ado, I'm going to ask Daniela Bacherini to talk about visual loss in a patient and how we might be looking beyond retinopathy. Thank you, Daniela.
Thank you, Tunde, and thank you to Euretina. Good evening, everyone. It's my pleasure to be here. Thank you for this opportunity. So we will talk about a case which reminds us that not all visual loss in diabetic retinopathy, in diabetic patients, necessarily are due to diabetic retinopathy. Sometimes we have to look beyond. So this is a case of a 32-year-old male patient with a long-standing history of poorly controlled type 1 diabetes. Over the years, he developed proliferative diabetic retinopathy, treated with bilateral PRP and multiple vitrectomies in both eyes for recurrent vitreous hemorrhages. Despite this, his visual acuity remained good, with 20/32 in the right eye and 20/20 in the left eye. And OCT scans showed no macular edema and only a DOMFL consequence of ILM peeling. But in February 2023, the patient presented to the emergency department with a sudden visual loss and a nasal scotoma in the left eye, and the visual acuity had dropped to 20/160. The anterior segment was normal, also the intraocular pressure was normal, and the fundus examination showed PRP scars without signs of new neovascularization or vitreal hemorrhage. This is FA that confirmed the absence of a significant residual ischemia and non-neovascularization. And in the left eye, we can see that FA revealed no signs of neovascularization, but an irregular staining and hyperfluorescence in the posterior pole. And these findings raise the suspicion of an alternative diagnosis. In the late phase of FA, we can observe a significant optic disc hyperfluorescence along with diffuse staining and leakage at the posterior pole. And these findings could be related to a disruption of the outer blood-retinal barrier in diabetic retinopathy, but can also support the suspicion of an alternative pathology. Despite FA not showing a significant residual ischemia, OCT angiography, macular OCT angiography clearly revealed bilateral diabetic macular ischemia, more pronounced in the left eye, both of the superficial and the deep plexus. The ischemic damage was more severe in the left eye, so consistent with the patient's sudden visual loss. Fundus autofluorescence showed extensive peripheral hypoautofluorescence in both eyes, consistent with the post-laser scarring. However, in the left eye, we can see a mild irregular hyperautofluorescence at the posterior pole, suggesting another process beyond the diabetic retinopathy. And finally, in February 2023, OCT revealed a new finding. If we look more closely at the OCT, we can observe 4 abnormalities: hyperreflective intravitreal dots, ellipsoid zone disruption, RP irregularities, and increased choriocapillaris reflectivity. So altogether, these findings were not consistent with the diabetic macular ischemia alone. And so if we compare OCT scans from January 2022 and February 2023, we can see that these changes were not present in the first scan and point towards a new active pathological process. And a wider A wider OCT scan confirmed the extensive involvement of the posterior pole, showing a diffuse outer retinal involvement, disruption in the left eye, widespread RP irregularities, and choriocapillaris hyperreflectivity and vitreous dots. These findings supported the suspicion of a posterior placoid inflammatory process. And a few weeks later, the patient also developed visual loss in the right eye, and we can see the same key OCT features previously observed in the left eye. So this bilateral involvement strongly suggested another process, maybe systemic inflammatory or infectious process. And given the bilateral visual loss and these OCT findings, the differential diagnosis included different diseases beyond diabetic macular ischemia. In another clinic, the patient had initially been suspected of having optic neuritis and underwent a 3-day course of intravenous steroids. However, MRI was normal and there was no pain, and the visual acuity remained unchanged, making optic neuritis less likely. So finally, given this picture and the OCT findings, an infectious workup was initiated, including syphilis serology that resulted positive. So based on these findings, the final diagnosis was acute syphilitic posterior placoid chorioretinopathy, and an immediate antibiotic treatment with penicillin was started. And in April 2023, after treatment, we observed significant anatomical improvement, and OCT showed the initial reconstitution of the ellipsoid zone. And these scans are after 1 month, and in June and September 2023, follow-up OCT scans showed further anatomical recovery. And after 1 year, we can see a good long-term anatomical and functional outcome. And so if in this follow-up comparison between March 2023 and March 2024, we can see a significant anatomical improvement with the disappearance of vitreous cells, reconstitution of ellipsoid zone and ELM, and the disappearance of pyramidal RP deposits and choroidal hyperreflectivity. So in conclusion, not all visual loss in diabetic patients is caused by diabetic retinopathy. When we observe atypical imaging findings, we must raise our level of suspicion and consider alternative diagnosis. In this case, multimodal imaging combining OCT, structural OCT, OCTA and other modalities played a key role in detecting signs that were inconsistent with the diabetic macular ischemia alone, and prompt further diagnostic workup. Thank you so much for your kind attention.
Thank you, Daniela. This was really a very, very nice and interesting case because you showed very well how these, let's say, acute changes in a patient that is a long-standing diabetic patient that was treated for a long time and probably was stable. So an acute event is always, let's say, suspicious. We should always evaluate very well the patient. So the imaging here, the OCT that showed both the changes at the outer retinal layers, but also the inflammation in the vitreous.
Yes.
And the comparison that you did, what was, let's say, some baseline or before this acute event and afterwards, the fine examining of the images and the changes, I think was really crucial to make, let's say, suspicious for some inflammatory changes. And I agree that also fluorescein angiography was important because you wanted to exclude any ischemia in the macula or something like that. And it was not the case, no? Yes. That you saw. So all of these different imaging modalities really helped to make, let's say, the hypothesis, what should you look for. So really very, very nice imaging and very nice case.
Thank you so much. Thank you. Yes, I think that it's important to focus on the ellipsoid zone in some, in these cases, and to compare with the other eye and with the other follow-up, to avoid unnecessary treatment or a diagnostic workup. Sometimes it's a very long history for the patient to reach a diagnosis. In this case, OCT alone was very crucial, together with other modalities, because the patient reported a palmar rash only after the diagnosis, and he told us that he had this skin manifestation that he had 1 year before the visual symptoms, but he remembered it only after the right diagnosis. So.
Yes, and sometimes, you know, the diabetic patients with proliferative diabetic retinopathy with acute, let's say, vision loss, we usually say maybe his metabolic control was not so good, maybe he had some hypoglycemia or whatever, and maybe would have overlooked the eventual other, let's say, diagnoses and investigations. Okay, so very, very nice. Yeah.
I think this is a very critical point, especially now that a lot of our patients are also on all the weight loss drugs. Some of them end up with some of the complications of very rapid improvement. And also people with diabetes are so numerous that they get diabetic retinopathy, but they also get everything else. So we always have to remember that just because they have diabetes, it doesn't mean that they can't have a second disease. And I think this is one of the issues why it's really good sometimes for someone else to see the patients, not always the very same doctor.
Yeah, great. Yeah. And Tien, you had a question?
Oh yeah, I just wanted to say, Daniela, very nice case. I think one thing that this case kind of reminds me of is that it's always very easy to look at positive findings, you know, on a OCT where you've got fluid or you've got SREM. The things that often get missed are when you've got absence of a structure that should be there. So like the ellipsoid zone. And I mean, your slides kind of show very nicely that the importance of looking at tracked or registered scans to look at change over time, because it's very easy to look at that second scan and scroll through, especially when there's other pathology going on, to miss the difference between the two. And yeah, the last thing I would say is that the other kind of scenario that this reminds me of is that you get patients with myopic maculopathy who already have some outer retinal disruption and they have sort of subnormal vision. And then one day they come in with acute vision loss and they're very sure it's acute vision loss. And you don't really pick up the problem unless you compare the scans and you realize they're missing, they've lost more ellipsoid zones suddenly. And often this is like a secondary mute or like an epimute or something like that. So that just reminds me, this case reminds me of that scenario very much. But yeah, beautiful case.
For this reason, thank you so much. For this reason, it could be important to make the OCT with a follow-up modality to have a comparison during the different visits to detect also the absence of a structure such as ellipsoid zone. Because sometimes the first OCT without ellipsoid zone, it seems like normal. So this is the problem. So you have to compare with the other previous scans and with the other eye at the very beginning.
Yeah, great. Thank you. So we will need to move on. Fantastic case. So now the second case will be presented by Gregor Reiter, when normal vision is not the full picture. Gregor, please.
Thank you, Stela. Thank you, Tunde, and thank you, Retina, for the opportunity to also present the case today. The title is When Normal Vision is Not the Full Picture, and here are my disclosures. So I'll present a female patient, 57 years old. She was first seen by a general ophthalmologist with very slight visual disturbance without any reduction in visual acuity. So this is something very usual in our outpatient clinic. Patients come with good vision, but something seems off. Family history: mother and grandmother experienced fatal complication related to stroke, and her sister, age 66, already had 2 strokes in her history. Visual acuity, and that is something we already know from general ophthalmologist, was very good, 20/20 both eyes. Here's the first impression right eye of our patient, visual acuity 20/20. This is As you can see, there's not a clear distinction between left and right. So this is a vertical OCT scan where you don't distinguish retinal nerve fiber layer from any side, but you can also see right side of the color fundus photograph. And it, on the first impression, looks quite all right. You might see some slight cotton wool spot here on the upper arch of the vessels. But when you look into the periphery, and it's quite small, but there is some kind of hemorrhage in the anterior section, and we also did a true fundus photograph, and you can see some slight hemorrhages here in the superior quadrant. But what you can also see here is that the vessels, the arteries especially, are very thin, and you might also see, especially on fundus autofluorescence, especially when you make an ultra-wide field autofluorescence, you can clearly see that the vessels don't stretch into the periphery. So you can clearly see some ghost vessels there, and that's something seems off in that patient. OCT angiography, also for first 6 by 6 millimeters, we do a macular area. In most of our patients, you can already see that there is some slight ischemia present in the lower left corner. And if we do some wide field OCT angiography, you see a much larger area of ischemia. The left eye, also vertical OCT scan, and to shorten it a little bit, you already see some ghost vessels in the periphery. As you can see, I think you see my mouse here, you can definitely see here the ghost vessels. Also starting here, the ghost vessels in the periphery quite clearly. And again, on the OCT angiographies, you see large areas of ischemic areas outside of the arcades. Ultra-wide field fluorescein angiography, we perform that as well. And you can clearly see the ischemic areas that we first saw on the OCT angiography as well. You see some slight leakage from the vessels, but very undistinctive. And on the left eye, you can see more or less the same, but in the nasal inferior quadrant, you can see some slight leakage. And this is, I can already spot it, this is from some macroaneurysm that are leaking there. So you can see, if you clearly look it up very clearly, this is some, I think it was 4 macroaneurysms in that area that show some leakage. So the interpretation of the retinal findings: narrow retinal arterioles with some ghost vessels in the periphery, some intraretinal hemorrhages, especially in the right eye, the fluorescein angiography, the non-perfusion of the posterior pole and the peripheral retina, and small amount of leakage due to retinal macroaneurysm. Further examinations. So the next thing is obviously the stroke history of the mother, grandmother, and the sister was very obvious to us. So we did a neurological counseling, and we further did an examination of her sister because of her strokes, and her sister revealed very similar findings in the periphery. You can see the fluorescein angiography and the Optos ultra-wide field fundus photos in both eyes. You can clearly see that the peripheral changes here also show some ischemia in the sister patient. So neurological counseling came up with cerebral leukoencephalopathy, and because of the examination of her sister, we came up with the idea that this might be an hereditary disease, and the genetic counseling revealed the variant in the Trex1 heterogeneous state. So the diagnosis, because of the Trex1 gene, is retinal vasculopathy with cerebral leukodystrophy. And this patient had an autosomal dominant inherited retinal vasculopathy with cerebral leukodystrophy present. The usual presentation in those cases is telangiectasia, macroaneurysm, cotton wool spots, capillary non-perfusion, and because of the capillary non-perfusion of the posterior pole, also retinal neovascularizations in the periphery. What we did in our patient, we did argolaser photocoagulation in the area of ischemia to prevent the vessel, to prevent neovascularizations forming in those eyes. 1 year follow-up, and you see that this disease is definitely progressing. We did some laser, you see the laser spots, but you also see that there is a lot of areas still missing with ischemia. So these patients progress, and the ischemia progresses much further on in these patients. You also see the macroaneurysms still leaking in those patients. We also performed wide field OCT angiography since it's now available, and we're following this patient now with the wide field OCT angiography as well. The procedure and follow-up too is, so the macroaneurysms remained active. We performed retreatment with the laser coagulation, and we now follow the patient with the wide field OCT angiography to see how the ischemic areas are progressing or if any new vascularizations are forming in those patients. Especially on the left eye, I want to show you that when you look closely, the typical presentation of microaneurysms are already present in this patient. So the disease progresses also in the macula, and this patient had good visual acuity of 20/20 in the beginning, but at the later stage, this patient also seemed to drop visual acuity quite fast later on. So take-home messages: monitoring tools are very important, especially ultra-wide field fluorescein angiography in those cases, which is invasive, or wide field OCT angiography, as it's now coming available, which is non-invasive, and it's very helpful to monitor the progression of this disease. The findings of this disease usually are very isolated, and sometimes you see these patients first in ophthalmology, which really helps to think about also neurological disease and also the collaboration with other specialties. Especially when you look at these pictures where you see that vascular retinopathy in those patients with systemic complications are quite early in the disease, and unfortunately most of these cases present with the death in their 60s or 70s years. Thank you very much for your attention, and I would like to especially thank Professor Stefan Saczuk, Professor Günther Weigert, and Dr. Müller for their collaboration in presenting this case. Thank you very much.
So thank you, Gregor. Very nice and let's say unusual, a rare case, because it's important to learn from this case. So this ischemia was really striking, peripheral ischemia. And so was it a different progression between the right and the left? In the right eye, you did not perform the laser. In the left, yes, but it was the progression. Did I understand well?
Yes, we performed laser in the left eye, which is exactly as you saw, but we did not perform laser in the right eye. We did not perform laser in the right eye because we did not see any neovascularization on the iris or any other neovascularization. So that's why we did not perform laser yet. I have to say the patient was not always the most compliant patient, so performing laser on the left eye was quite difficult already, so that's why we did not do it on the right eye. And you saw that on the left eye. Personally, I would love to have a little bit more of the area covered with the laser, but unfortunately that was not possible with the patient. But obviously, we advise to see regular checkups, and it's much easier to perform the non-invasive OCT angiographies with her, since always injecting dye for fluorescein angiography is much harder for her. So doing a wide field OCT angiography is very easy for her to follow up, but everything invasive is much harder for those patients.
So Gregor, would you always suggest, when we see the case, the patient with a lot of, let's say, ischemia, this peripheral ischemia, and not knowing anything about this patient, to let's do some systemic workup to understand better when you see a lot of...
Well, ischemia, and I think that's quite clear, ischemia must come from some vascular disease. Ischemia doesn't also present in the eye without any vascular disease. Might it be from a vein occlusion? Might it come from a diabetic retinopathy? Does it come from any other possibility of any vascular disease? So yes, in the case, which is often the case in the more frequent cases, which is diabetic macular edema or retinal vein occlusions, we send all these patients to their internal doctor for a checkup, for some ultrasound investigation, for some blood tests. So this is something where it's definitely advised to send all these patients to a general doctor or internal medicine talk for a checkup. So yes, definitely.
So before we move on to Dinah, can I just say that it can be very difficult to decide on the peripheral retina as to what is normal for someone. So sometimes ischemia is not quite as easy as we would like it to be. So, so especially if you do follow-up, that also helps, and also peripheral OCTA, if you now have it, or wide field OCTA can really help, because some patients have completely normal retina in the periphery, even if it looks ischemic. And sometimes if you have quite a bit of cataract or other bit opacities, it can be very difficult to decide. So it's important to think every now and again when we do these examinations. So thank you very much. We're going to move on to Professor Dinah Zort, who will be talking about white dots and fading vision. Thank you, Dinah.
Thank you, Stella and Tunde, for inviting me and for Euretina for organizing this. So my case starts a little similar to Gregor's case because we have a 76-year-old lady and she is visiting her general ophthalmologist with very unspecific vision disturbances. She has blurry vision for 1 year. So she has some systemic history. She has hypertension, which is well controlled. And she also has some oncology background. She had colon cancer some years ago, which was successfully operated on without any further treatment. But she lost a lot of weight around the surgery. But since then, she's happy with her new weight. And she does get some ferritin because of anemia time to time. But apart of that, she is active and doing well. She already had cataract surgery. And when her general ophthalmologist saw her the first time, her vision was 615, 620. IOP was normal. And there was some asymmetry between the optic discs. And when he did the visual field testing, there was scotomas in the upper part of the visual fields, as you can see here. But it was attributed to the disc asymmetry. And after performing an OCT scan, this is a horizontal scan of both eyes, which encompasses through the fovea, as you can see, and all the layers are preserved, so a retina etiology was excluded. And on the OCT, RNFL and GCL scans, you can see that there's some thinning, mainly in the temporal part, also in the inferior part, and this was compatible with the defects that were seen on the visual field at that time. So she had some general checkup and also MRI of her head, and everything turned to be normal. And this is why she was diagnosed with normal tension glaucoma at that time. She got treatment and followed in the outpatient clinic. And she came back only 3 years later, and this is the time we saw her first. And she was complaining on dry eyes, worsening vision, very unspecific complaints. Her vision is now 630 and 640. The IOP is lower, and she's taking her treatment. And this was her first visual field testing. And it doesn't look that different, but if we look at the mean deviation, we can see that it is getting worse over the last 3 years. And also the fixation is now a bit more involved, and the total deviation is lower than at the first time. And I'm sorry for the quality of the images, but you can see on the pseudo-color images of the optos that there are many, many yellowish dots in the mid-periphery in both eyes. And there is some disc asymmetry. There are some atrophic lesions which are not that relevant to the case at the moment. On the fundus autofluorescence image, you can also see that there are some hypoautofluorescence dots that start around the area of the temporal arcades and also nasal to the disc. And those were compatible with the yellowish dots that we saw clinically. And this is her baseline OCT, which I showed you before. And now I'm showing you what it looks like 3 years afterwards. So we do see thinning of the inner layers, but also, of course, irregularity of the outer layers. And there is some granularity of the ellipsoid zone and some hyperreflective dots above the RPE. And you can see on the map that there is general thinning of the retina compared to the previous images. If we do a scan that encompasses through the extrafoveal area, you can see that those little yellowish dots are represented at hyperreflective dots above the RPE. And when we talk to her a little more, and her husband is also involved in the conversation, he's saying that he has all the time to change the lights because she doesn't see enough when she enters the house. And then we look again at the anterior segment of the eye because of her dry eye symptoms, and it doesn't really look like a general dry eye, but there is something that is suspicious of big dot spots. And when we did the full field electroretinogram, you can see that there's no scotopic response at all. In the red box, you can see our patient. So after dark adaptation, there's no response at all of the rods. And this is the normal response in the blue box. And the photopic response is a little bit reduced, but her peripheral cone system is working quite well. And when we ask her again, she is indeed complaining that she has much worse night vision during those last years. And when we take together the complaints about night vision and those white retinal deposits, then we have a differential diagnosis of some congenital conditions such as fundus punctata, or inherited retinal diseases like retinitis punctata albescens, but also both of them don't really fit our patient. She's 70-something years old, and she's just complaining in the last years. We can also think about something paraneoplastic because she had some oncology background, and as she lost a lot of weight after the surgery, we are suspicious of vitamin A deficiency. And before we do any further workup, she really gets back with very, very low vitamin A levels. So in the Western world, we're not that used to see vitamin A deficiency, but we do see those patients with some chronic IBD diseases or after bariatric surgery, or like our patient who have gastrointestinal surgery. And when we look at the WHO grading system, she's actually at the lower bottom. She has xerophthalmos fundus. And I'm not going into the pathophysiology too much, but vitamin A deficiency primarily affects the rod system. And when we talk about imaging, we can see those punctate white dots in the mid-peripheral retina as she had. And those are a little bit similar to subretinal deposits, which are related to shedding of the photoreceptor outer segments. And also there is some description of reversible ganglion cell thinning. So what was initially diagnosed as glaucoma might have been something completely different. And I just want to give the credit to Ido Perlman, who's my mentor, and working with us, who was the first to describe the ERG, which is reversible after you give the vitamin A back in a parental way. And this is what we did with the patient, and she really improved with her symptoms. As just to remind you that there are things that are hard to catch when we ask the patient about the symptoms. We really have to have a high index of suspicion for such things. And thank you very much.
So thank you very much, Dinah. This was very interesting and also reminds us that we also have to look at the anterior segment and we have to think about the general health. And I think this is a recurring theme at the moment that we can't just be thinking about the retina in a very, very narrow way. So can you tell us a little bit more about the ERG? Like if you don't really do much ERGs, what is it that you would be looking for on those lines?
So first of all, maybe something more common to see is the pseudoreticular drusen that we see in AMD patients, and they're also complaining about reduced night vision. And those is really an easy way to look at some rod problems on the OCT. When you see many reticular drusen in the mid-periphery, those are going along with those nyctalopia things. And in a patient like this, we are actually listening to the patient when he's telling you that there's a difference between his night and his day vision. The first thing you should do is a full field ERG, because it's the only way to differentiate between the cone and the rod function. And there are some subclinical things, but if it's vitamin A deficiency, it's the most easy diagnosis to make, because you have an absent rod response and the cone function might be reduced, but it's much better in comparison to the rod function.
Dinah, great case, really. I learned also a lot. One question for you. So when you make the diagnosis in these cases and you start the treatment of the patient, so what would be, up to you, the best imaging modality or modalities to follow up the patients and to see, let's say, the recovery? How would you follow up this patient with the imaging?
So the easiest way is to listen to the patient, because usually after 1 month, they're much happier already and they tell you that the symptoms have improved. We usually do an ERG about 1 or 2 months later to see recovery. And the patients that we have very long-standing deficiencies, they might not completely recover in the outer retina, because when you already see those changes, it might be irreversible. But we do have some that you see some regeneration of the outer retinal changes that I just showed. So it depends on the chronicity.
On the chronicity. And does the morphological changes of the outer retina parallel the functional findings, for example, on the ERG, or what is your experience? Or it is sometimes, let's say, not in parallel?
It's not always in parallel, and the worst cases we have are the oncological patients that had resection. If they had bariatric surgery and you substitute them on time, they do recover morphological and functional. That is what we saw. But those very chronic changes, they might be irreversible.
Mm-hmm. Okay, thank you. Great case, really. Thank you very much, Dinah. Thank you very much. So the next case will be presented by Tien-En Tan, a matter of perspective. Tien-En, please.
Thank you. Good evening. Thank you, first of all, to Stella and Tunde for the kind invitation to share these cases. I'm going to show a short series of cases that I think hopefully will convince you that sometimes it's a matter of perspective. So first case is a young gentleman who's a low myope. He comes in with a history of episodes of visual disturbance in the right eye, each time lasting about a month and then going away. He presents with good vision in this eye, 675. And you can see on the color fundus photograph, there's some changes in the peripapillary region, some evidence of RP atrophy. And this also corresponds to what you see on the fundus autofluorescence. Just temporal to the disc, there's some hypoautofluorescence, probably indicating the atrophic change. And just superior to that, you get the hyperautofluorescence, indicating that RPE is sick or unhealthy. He also comes with superior paracentral visual field defect. And if you look on the OCT, this does kind of confirm the suggestion that there's outer retinal changes in the peripapillary region. So on the OCT, you can see that there's outer retinal loss and atrophy of the ellipsoid zone and some irregularity of the RPE. So this patient was referred in with a diagnosis that he was on the spectrum of acute zonal occult outer retinopathy or acute idiopathic blind spot enlargement syndrome. And the referring physician had already done an infective workup to exclude, posterior placoid retinopathy, as syphilis was negative. So you can see these are the kind of changes they were concerned about, outer retina, mostly in the peripapillary region. So the question here is, are we convinced by the diagnosis? This is what the patient looked like about a month or two later when the patient came to see me. You can see that there's still these, temporal peripapillary outer retinal changes. But there's a suggestion now that maybe it's not a completely dry disease. You can see maybe a suggestion of a kind of sliver of fluid there, which kind of suggests that maybe the diagnosis is something different. And so the point here is, is there anything else that we can do that may be quite simple to figure out or to elucidate what the diagnosis is? And the answer is yes. So if you do, so what we were seeing before were horizontal raster scans, which is the typical OCT that we normally, most of us are used to looking at. And it's not routine always to do a vertical raster, but as I hope to demonstrate, if you do a vertical raster, sometimes it gives you a lot of information. So this is a vertical scan, and you can see that it cuts across, and that this patient has quite unusual scleral choroidal contour. And if you look at the consecutive vertical raster scans, you'll see that all the outer retinal changes in the nasal macula are kind of concentrated at the apex of this curvature, or at the dome. And so really what this patient has is dome-shaped maculopathy, or a variant thereof. And so, I think this kind of illustrates how if you look at things from one point of view, you don't necessarily see the pathology. And if you do a simple thing, like if you have an index of suspicion, you do the vertical raster, then the pathology becomes a lot clearer. I'd also like to point out that as you see this kind of change in the scleral choroidal contour, there's also quite a significant change in choroidal thickness as you go along. And this is one of the hallmarks of this condition. In a similar vein, this is an older lady who was walking around with a diagnosis of recurrent CSR for many years, and she reports these episodes of recurrent metamorphopsia. And if you look at the OCT scans, again, these are horizontal OCT scans. She's got multifocal neurosensory detachments. In the left eye, it's subfoveal, and in the right eye, it's extrafoveal. And I think one of the important imaging clues here is on the left eye here. As you go down the horizontal raster scan, once you get to the bottom, you see that the focal plane is different. So the focal plane of the inferior macula is in a different place, and that's why you're starting to get the reflection of the OCT image. And as I'll demonstrate, I think this is probably quite a useful sign to suspect that there's something not quite correct in the vertical dimension. So this is her a few years later. I think this was last year. You can see that her fluid in the right eye kind of fluctuates. Sometimes now she's got a bit of irregular RPE, and she's also got some Shrem. Another colleague had done a Fluorescein angiography, which they felt was consistent. They thought that this was maybe late leakage related to a nasal ink blot, and she's still labeled as chronic CSR. So when I saw her this year, you can see she's still got the subfoveal Shrem, but really if you do the vertical raster scan, then the image becomes clear. Just looking at the horizontal scan alone, you really wouldn't suspect this, especially if you don't go through the whole thing. And once you do a vertical scan, you can see she's really got a dome shape, and a lot of the pathology is centered on the dome. So she's got dome-shaped maculopathy, and also if you look at the left eye, you can see that the horizontal raster scan looks pretty normal, except maybe for this temporal area, but the vertical raster really gives away the dramatic kind of change in slope and contour. Similar kind of case, this is a patient who was diagnosed with bilateral recurrent CSR for many years. And again, she has like fluctuating fluid. She keeps coming back with sometimes subfoveal fluid, sometimes fluid further down in the inferior macula. But if you do the vertical raster scans, you can see that what she's got is that this is the inferior part of the macula. So she's got a bit of a posterior kind of staphyloma, and quite often this is centered on the inferior macula, and the fovea is really on a slope, and she's got this kind of symmetrical pattern in both eyes. So again, showing how the vertical scan gives a lot of information. So one thing I would like to point out as well is that if you look over here, you can see that when you look at your near infrared image on the OCT, I hope you can see the pointer, you can see that the inferior macula is in a different focal plane. So the rest of it, you can see that is in focus, and then this inferior macula goes out of focus, which again tells you that there's something going on, and that by right, most of the time, you generally expect things to be in the same focal plane. And just to end off very briefly, this was an elderly gentleman with type 1 CNV in the right eye. You can see here he's got irregular shallow RPE with a little bit of fluid. He was treated successfully with Avastin. The RPE elevation, the PD went down. But if you look at the vertical, clearly he's got dome-shaped macula, and dramatic change in the choroidal contour in the superior choroid and the inferior choroid. Lastly, this is a case of polypoidal choroidal vasculopathy. This photograph shows serosanguinous detachment with succinate hard exudates, which is quite typical. And on the indocyanine green angiogram over here, temporal to the fovea, you see a bunch of polypoidal lesions. The OCT kind of looks like what you'd expect. Mostly, you've got this irregular notched pigment epithelial detachment, which is where the polyps underneath. But one thing that may be a little bit atypical in this case is that the choroid is really quite thin, which is not impossible, but is a little bit unusual for PCV sometimes. So this patient had Avastin and focal laser, and you can see the polyp regressed. But if you do a vertical scan, you can see that this patient again has a kind of like inferior staphyloma, and just at the crest or at the dome of the staphyloma, that's really where the now regressed polyp is sitting. And this has been well described that a proportion of PCV patients actually have polyps at the edge of a staphyloma, similar in a way, I think, pathologically to a dome-shaped macula. So just take-home messages. I think dome-shaped maculopathy and the similar abnormalities of the choroidal scleral contour are probably significantly underdiagnosed causes of neurosensory detachments, outer retinal atrophy. Quite frequently, they masquerade as CSR. And also they can be an underlying structural predisposition to secondary lesions, like a choroidal neovascularization or a PCV. I would encourage you to think of the retina in 3 dimensions, not just 2, and really ask for vertical rasters when you suspect it. I think the clues that should sort of make you suspicious when you have a thinner than expected choroid in a patient who's walking around with a diagnosis of CSR. If you're looking at the consecutive horizontal rasters, if you see the retinal position changing a lot or the choroidal thickness varies a lot, then you might want to see something in the vertical dimension. And lastly, as I mentioned a couple of times, when you've got confocal imaging or you've got the non-infrared, the near-infrared image rather, that's easily available, and you see one area is just in a different focal plane, that should encourage you to do a vertical raster. And often you get that gives you the clue to the diagnosis. So yeah, thank you very much.
Thank you, Tien. Thank you. Really very nice cases. And you showed very well how it is important to do both the horizontal and vertical imaging the raster. So I'm asking you, let's say in a busy clinic, when you do your map, we usually do just the horizontal, I think, most of us at least. Do you think it's enough then to do just a single B scan that is vertical and horizontal, or you might miss the, for example, dome shaped in this way?
Yeah, I think that's a great point. I will say that in my clinics and my practice, we routinely just do the horizontal scan. I mean, the verticals are not routine. I think it's to me, it's kind of, you need to have an index of suspicion. Obviously, it's nice to have everything, but at the same time, you don't want to have, you know, too many imaging modalities in a busy clinic that holds up imaging. It's difficult to look at. But you're quite right. I think if you wanted to have a sort of in between, and you to do the vertical, a single vertical raster would be very helpful and would probably pick up a lot of undiagnosed cases. But I think for most people who just rely on the horizontal scans, which is not wrong, I think it's more about maintaining a healthy index of suspicion. When something doesn't seem right, something relatively simple, sending the patient back to the imaging room and asking for that one thing can really elucidate the diagnosis. And as you see, some people are walking around with diagnoses that weren't quite correct for many, many years.
So there is a question from the audience, from Lars Kreisberg for you. Tien, normally a horizontal scan will pick up dome-shaped macula unless the software is set to carry out alignment.
I'm not sure exactly what the alignment function is referring to. I mean, if anybody else on the panel is familiar with it. I mean, in my experience, if you have got a significant vertical or dome shape, as you see the horizontal rasters, as you scroll down, you will see significant change in position of the horizontal, and that's a clue. But again, it's one of those things where if you're not looking out for it, you might not see it. But if there is a function there, I'd be sort of very curious to know about it. I'm afraid I'm not that familiar with it.
Does anyone comment on this? I also agree with you that there are, I would say, quite often the cases that you cannot see on the horizontal scan the dome and you see it on the vertical. Of course, the cases that are so obvious, even when looking at the fundus, you say this may be the dome shaped. That's, let's say, these are easy cases, but those subtle ones are obviously more difficult. And then I really think that the vertical scan is crucial.
What we do here in our clinic is the technicians take one vertical and one horizontal for everybody. And because they're so experienced already, they catch the dome, and then if they see it, they just go for the vertical volume scan, and it's really helpful, and not, you know, sending the patient back and forth.
Yeah, that's a good point, Dinah. So the technicians who is performing the OCT scans needs to be aware of this possibility, needs to be trained about this. Okay, great. Thank you, Dinah.
Yeah, thank you.
Okay, so now we are going.
Thank you very much.
Yes, Tunde, please go.
You go, Stella. So thank you very much, and we're going to be introducing our last speaker, Enrico Bernardi, who will be talking about peripheral and central retinal disease.
Hello, everyone. Good evening. Thank you very much for this opportunity. Today, I'm going to speak about fluorescein angiography and some of its potential uses for both peripheral and central retinal disease. The first case is going to focus on the peripheral retina, and it involves a 9-year-old boy who was referred by an optician to us because of a left eye vitreous hemorrhage and a suspected retinal detachment. The family of this child came as refugees from the Ukraine, and therefore communication with them was quite limited, unfortunately, also as no translator was present. However, his mom could speak some English, and she essentially explained us that the patient had screen surgery done 3 years prior, but otherwise, as long as she knew, never had any eye issues before, neither him nor any of his siblings. At presentation, visual acuity of this patient was in decimals, 0.8 in the right eye and 0.25 in the left eye. So when we look at the fundus photo of this patient, looking at the left eye, what we can noticeably see is that there's extensive flame-shaped vitreous hemorrhages. There's a vitreous retinal traction extending from the optic disc towards the temporal bit of the eye. And also very notably in the extreme periphery, as you can see here, there's a yellowish whitish lesion, which is essentially a very, very big neovascularization with what you cannot see here that well, unfortunately, an area of raised and pronounced retina, which ended up being detached. It, however, looked like an exudative detachment and not like a tractional detachment. Here is another close-up of the inferior temporal retina where you can see even more blood collecting at the bottom. We obviously also looked at the other eye, which showed also an involvement, albeit quite different. So you can notice that the retinal vasculature sort of flows up to a point where it gently stops at this faintly visible line that is highlighted here by these two red arrows. So essentially, the retina afterwards on the temporal side of the image is avascular. So the diagnosis in this case was quite easy, and it was of familial exudative vitreoretinopathy, also known as fever, which in this case, especially in the left eye, was stage 3 because of an extramacular retinal detachment with exudations. We decided, however, to perform fluorescein angiography examination as well. What you can see here in the FA of the left eye is that the vessels are very clearly stretched towards the temporal periphery, which is a quite prominent feature of this disease. You can also see extensive leakage in proximity of the neovascularization, as highlighted here. And you can also see the retinal hemorrhages as shadows casted upon the picture as well in the center. This is another close-up of the area closer to the neovascularization with very, very extensive leakages. The FA looked quite interesting in the other eye as well, because as you can notice now, the line is not faint anymore. It's very pronounced and very clearly delineates where the retina is perfused and where the retina is non-vascularized. What you can see here in this other close-up as well is that whenever the retinal vasculature stops, the underlying choroid vasculature is very nicely visible as darker lines in this non-perfused retina. In this case, even if it was a stage 3, which usually requires vitreoretinal surgery or at least scleral buckle, we decided to just go ahead with indirect laser photocoagulation since the detachment was serous, which you can see was applied here in the avascular retina in the right eye and in the left eye. And this turned out for the best, as the visual acuity went up to 0.5 a few months later, and as up to this day, the retina is still attached in the eye of this patient. I'm now going to move on to the next case, which focuses on the central retina instead, and involves a 61-year-old male who was referred to us because of an eye flickering that had been bothering him in the left eye. The patient had been known prior to our retinal service, was last time seen 6 years before this time, and he had a diagnosis of bilateral pigment epitheliopathy of unclear etiology. At the time, multifocal ERG was abnormal in the right eye. It showed reduced amplitudes. However, I could not find a detailed report, unfortunately, about this. He also had extensive uveitis diagnostics performed, which, however, was completely non-conclusive at the time. One of the differential diagnoses at the time was also Azor, but unfortunately, the patient just stopped showing up at our clinic and did not attend multiple times despite appointments being scheduled. So until this time, when he noticed something changing. So this time, when he presented, his visual acuity was very different, since it was hand motion in the right eye and 0.6 in the left eye, which was much worse than 6 years prior, when it was 0.2 in the right eye and 1.0 in the left eye. You can see here a fundus autofluorescence picture of the right eye, of how it looked like in 2017 and at this presentation. As you can see, there is very pronounced changes. This time, there's a very extensive area of atrophy, which is visible here as there's a hypofluorescent area around the optic disc and extending all the way up to the fovea in the macula. What is quite interesting in this picture is that, of course, there's not just this one focus. There's many foci, especially superiorly here. And if you look at this close-up, the edges of this lesion are hyperfluorescent, which in these cases indicates, hyperautofluorescent, which in these cases indicates an activity of the lesion, whereas the hypoautofluorescent spots just indicate usually just generally older changes or lesions. The other eye indicates a similar situation. You can see that the progression was much less pronounced here, but all of these three areas of changes, these three lesions, have slightly extended. And what is also visible here is that the edges are much more hyper autofluorescent, indicating here also quite some sign of activity. So I would just like you to take a look at this color fundus pictures and try to visualize the same changes, just apply to what you would see, for example, at the slit lamp using your lens. There are some changes that are faintly visible, but they're of course not as pronounced, and it's also much harder to tell what the borders of these are, how extensive these are, and how many other active tiny little foci there are. I mean, these areas would roughly correspond to this area in the right eye and these areas in the left eye. We also decided to perform an indocyanine green angiography and fluorescein angiography, which you can see here for the right eye. How these lesions are portrayed in these photographs essentially is a very nice window defect that you can see here on the left in the ICG examination, which shows very clearly and beautifully the underlying choroid. Whereas in the early stages of the fluorescein angiography, seen here on the right, you can see the underlying choroid through this lesion, this defect of the RP, and you can see it as a hyperfluorescent patch area or tissue, essentially. Here you can see a late stage of the ICG examination, which shows diffuse granular hyperfluorescence, also indicating the extent, essentially, of the amount of lesions being active at the moment. We did the same for the left eye, which also similarly shows this window defect, which show the underlying choroidal vasculature quite nicely, and which show these slightly hyperfluorescent areas similar to the other eye. Here you can also see an early filling stage of the ICG for the same eye, and you can see this very interesting pattern of filling of the fluorescein for the same eye, which is also nicely visible through this superior defect of the RPE along the arcade as well. So here you can see how it continues. So in conclusion, both fluorescein angiography and andocyanine green angiography are very helpful diagnostic tools for both peripheral and central pathology, as we all know. And they can be very helpful in detecting both avascular and non-perfused zones of the retinal choroid. Window defects can sometimes also be used to highlight atrophic areas in the choroid capillary that are otherwise not as clearly visible in fundus photography examinations. Thank you very much.
Thank you, Enrico. Thank you. Very nice cases. So I have, let's say, a provocative question for you. So if you had in your clinic the wide field OCTA, would you still perform the fluorescein angiography for the detection of ischemia, as you pointed out in your, let's say, second point, the ischemia of the retina, even in the periphery? Do you think it would be?
Good question. Probably not. I mean, I would prefer to avoid relatively invasive procedure if I had something else available. At the time, we didn't have any wide field OCT angiography available, so we unfortunately had to use these. But if I had one available, I would probably prefer doing that first. Definitely.
Still let me, because I showed these images between fluorescein angiography and OCT angiography. The issue is, yes, OCT angiography is fast, it's non-invasive, but from a field of view, the fluorescein angiography still goes further than the OCT angiography we have so far. So if we're really looking to the far periphery, the fluorescein angiography is definitely a valid reason, or definitely a valid monitoring tool. If it's something more central or mid-periphery, I would definitely go for the OCT angiography, but fluorescein angiography does have its reason.
And maybe also, if you're talking about pediatric ophthalmology or pediatric retina, I think we cannot do without the FA. I mean, it's nice to have those nice OCT images, wide field, but there's no chance a child will sit down and have those long acquisition times.
No, very good points of view. And I have one last question for all of you. So what do you think about the ICG? Do we still need it? and what are the pathologies that we still use it? Because I would say definitely in AMD, we are using it less.
I mean, I would say, I mean, from where I come from in my part of the world, we routinely still do a lot of indocyanine green angiography in patients who have, neovascularization secondary to AMD. And for us, it's because of the proportion of polypoidal choroidal vasculopathy in our population. I mean, OCTA can sometimes show up the polyps, but, because there's turbulent flow in the polyps, you often miss the polypoidal lesion on the OCTA just because of the flow threshold. And so it's often below the flow threshold. So for us, we still find we don't have a good replacement for that indication. Yeah.
I'm doing a lot more now than back in the days, because I feel like a lot of my, especially AMD patients, some of them develop polyps secondarily. So I have some patients that are very hard to treat, which take up injections every 4 weeks. And we do ICGA, and then we realize there's a polyp, we might do a PDT. So it's definitely worth doing ICG from time to time if you have some suspicion of polyps or some other pachychoroidal diseases. Yes.
Okay, Dinah, would you like to comment?
I do it quite a lot because I do see a lot of CSR patients. So before doing the PDT, and also for inflammatory diseases,
yeah,
I think we need it.
Yeah, for the inflammatory, definitely. That's something we still need. Enrico and Daniela, would you just like to comment where you use it?
Agreed, especially for inflammatory diseases. However, we do not use it quite as much here as possibly in other centers.
Yes,
Daniela?
I agree. For inflammatory disease, it's very important. I agree.
Okay, so thank you all. I think this was a fantastic session because the cases were so nice, so informative. I also learned a lot, and we also how important it is to look very detailed into imaging. It's not everything like fluid yes, fluid no. We have a lot of more signs that we should look at. So I hope this was useful also for all our colleagues around the world. Looking forward to seeing you all soon, and have a great rest of the evening or of the day wherever you are. Thank you all very much, and bye.
Thank you.
Thanks.
Thank you.
Thanks. Bye.